Thamer, if you can go ahead and share your screen. Perfect. Thank you.
Hello, can you hear me?
Yes, we can hear you. We can see your slides and the side bit. There you go. We can see the slides now. Thanks.
So welcome everyone. First, I want to thank you all for attending today's presentation. I also want to express my gratitude to Dr. Marcon for giving me this chance to present today. I'm also happy to be presenting for the second time at TM Rounds. While I'm not an expert in passenger lymphocyte syndrome, I had the chance to learn about it during one of my rotations here, and it has left me excited to share this topic with you today. So I have no conflict of interest to disclose to that any relevant of this topic today. So for our objective for today, today's presentation are to just describe the passenger lymphocyte syndrome, to explain the pathophysiology, also to discuss the clinical course, identify the risks, and the how to approach and detect the detection and management for this case. So we had a case for a 64-year-old male with an end-stage liver disease from hepatitis C, who was also recently underwent a liver transplant. He had a history of hepatocellular carcinoma, which was treated a long time ago. The patient developed severe thrombocytopenia, less than 5,000, and his hemoglobin dropped from 129 to 85, 7 days post-transplant. There was no history of recent blood transfusion in the last 3 months. So initially, several differential diagnoses can be considered based on the patient's medical history, multiple comorbidities, and the observed decrease in hemoglobin level and platelets, and could be delayed hemolytic transfusion reaction, and autoimmune hemolysis, microangiopathic hemolytic anemia. It could be also drug-induced hemolysis or passenger lymphocyte syndrome. So it is important to carefully differentiate between all these entities, as their treatments are completely different. The presentation, laboratory, and morphological findings can help us distinguish between them. For example, an acute hemolytic transfusion reaction, usually hemolysis occurs immediately, mainly due to ABO clerical error. This is the most common cause. Patient might present differently from a patient, let's say, with a drug-induced or autoimmune. Also, we can see that the patient in autoimmune hemolytic anemia has maybe a history of autoimmune disease, usually associated with a positive DAT for IgG, also a positive autocontrol, a pan-reactive panel. In patients with, let's say, a drug autoimmune hemolysis, this could be immune-mediated or non-immune-mediated, and there's usually a history of like a drug for anti-malarial drug or antibacterial agent, and usually also the presentation morphology differs if it's immune-mediated or oxidative stress that occur. And lastly, we have the microangiopathic hemolytic anemia, including TTP and the IC and HUS. Usually, you see different symptoms. Of course, for TTP, we have the pentad, thrombocytopenia, anemia, fever, renal, and CNS involvement. On the other hand, for DIC, it can present with bleeding and thrombosis. The morphological findings also here are distinguished by the increased number of schistocytes and microspherocytes. So back to our case. So our patient had a positive hemolytic workup. He had an elevated LDH, he had elevated bilirubin and a low heptoglobin level. Peripheral blood film showed no significant schistocyte or microspherocyte. A sample was sent to the blood bank, which revealed a weakly positive DAT for IgG. The patient's blood type was O positive, while the donor blood type was O negative. The patient also was phenotype. The patient phenotype, as you can see, is B positive, big C positive, big E negative. and so on. The elution was process confirmed the presence of NTD. Again, there was no history of recent blood transfusion in the past 3 months. So how can we best define and describe PLS? So it's a rare condition that occurs following a solid organ or hematopoietic stem cell transplant. It is characterized by the transfer of B lymphocytes from the donor graft to the recipient circulation, leading to the production of antibody against the recipient red blood cells. So let's go back to the 1980s, where it was initially discovered in patients who was receiving a minor mismatched renal allograft. PLS occurred when a viable, again, B donor lymphocyte passively transferred to the recipient within the allograft and formed antibody that resulted in the red blood destruction. So by 1991, there was more than 100 cases involving liver, kidney, pancreas, spleen, heart, lung, and heart-lung publishing was published. Articles was published. So the main etiologies for the PLS can be seen in, again, solid organ transplant, stem cell transplant, and also there is an administration of B cell-rich cellular therapeutic infusions. They can be seen with minor, for example, we have a donor of group O and a recipient of group A. This is the most common type. Also, they are also reported in other blood group systems like the RH, KIL, Duffy, and KID. Usually what happens, the donor lacks the recipient antigen. So let's say the donor has little or big E negative, and the donor will form antibody against the recipient of blood cells, which you can see is here like big E positive. So just as a reminder, there are 3 types or 3 groups of ABO mismatch can be distinguished in hematopoietic stem cell transplant. We have the minor, which is the most common thing we see in PLS. We have the major and the bidirectional ABO incompatibility. For the minor, as we said before, it could be an O group donor to an A, B, or AB. And for the major ABO incompatibility, we can see it for patient for donor with AB to O, or A and B. Also in the bidirectional ABO incompatibility, this is usually seen in a donor with A who's giving a recipient to be a B donor, a patient, or otherwise, the other way around. So what is the pathophysiology for PLS? PLS is actually an under-recognized complication of solid organ and stem cell transplant that usually leads to delayed hemolysis. This is the main feature. It is a type of graft versus host disease. The mechanism behind PLS is as follows. During the transplant, donor lymphocytes are transferred, and they are recognized antigen present on the recipient red blood cells. This triggers a humoral response, resulting in the production of IgG. So mainly IgG is produced. However, in less common situation, you can see an IgM antibody 4, which usually cause that positive hemolysis. So what is the clinical course? Of course, a sudden onset of hemolysis from day 5 to 15 post-transplant, usually around day 9. It is self-limiting, mild hemolysis lasting for 10 days. Again, it's IgG-mediated usually. It's extravascular hemolysis that is positive for 2 to 3 weeks in liver transplant and up to 5 weeks in renal transplant patient. However, rare cases are seen that can last up to 1 year. So since hemolysis is generally a self-limiting long-term follow-up, study showed no increase in mortality rate. However, it does cause a significant morbidity as patient also requires multiple transfusions during the hemolytic episode. While rare, there have been reports that in the literature that massive hemolysis is leading to like kidney injury or DIC. So the donor lymphocyte will eventually fail to self-renew, of course, or the graft lymphoid tissue will develop a tolerance toward the recipient antigen, and this will stop further hemolysis as the antibody production will decline after that. However, rare cases have been reported to continue up to 6 months after the start of hemolysis. And this implies that once the transferred and stimulated B lymphocytes or plasma cells are capable to sustain a new antibody production. So, of course, although it is rare, again, we have to monitor the patient for severe signs and symptoms for acute hemolysis. This includes, of course, hematuria, hemoglobinemia, flank pain, fever, shock, and hypotension. Just these symptoms are usually seen in acute hemolytic transfusion reaction as well. So, what are the risk factors that for developing PLS? So there was a prospective study of around 1,000 liver transplant patients from Spain. It showed no clear demographic risk factor. The data in the literature does reveal some factors. Of course, as we said before, minor mismatch is the most common type of risk factor that you could have. Other possibilities are pregnancy, previous pregnancy, or previous sensitization, or from at least previous blood transfusion. Usually also, I'm not sure, but sometimes drugs like cyclosporine, I'm not sure if the clinical side have switched from that. However, the use of cyclosporine in the absence of anti-proliferative agent, such as methotrexate for post-transplant graft versus disease prophylaxis, usually you can see that. An infection immediately after the post-transfusion period, the use of peripheral blood as a source of hematopoietic stem cell transplant. So for solid organ transplant, the incidence of PLS following solid organ transplantation has been reported to be around 9%, 29%, and 70% for kidney, liver, and heart-lung transplant, respectively. These differences are likely to reflect the amount of lymphoid tissue implanted within the corresponding organ transplant. So here we can see in 1984, there was a landmark study by Ramsey, and it shows that the isohemagglutinin cause most cases of PLS in liver transplant patients. So the meta-analysis was performed in 1991, showed that anti-A and anti-B was responsible for the majority of PLS, and the other solid organ transplant patient as well. And the patient receiving organ that were rich in lymphocytes, such as the liver or heart, lung, had the higher rate of PLS. This study showed that anti-A from O donor was the most common cause of PLS in solid organ transplant patients, with around 61%, and 21% for O to B patients. And that patient with the A2 phenotype was not protected against this phenomenon. So PLS due to a non-ABO allo antibodies can be any clinically significant allo antibody. Anti-D is the most common type. Rare cases of little c, little e, JKB, JKA, Duffy, and KIL has also been reported. The question is, are donors usually immunized previously? So it has been suggested that donor may have been already exposed to these antigens in the past, which suggests that PLS may be a more predominantly due to a secondary response rather than a primary immune response, which also could explain the timing of the hemolysis that usually happen later on. So what kind of conclusion can we draw regarding PLS in liver transplantation? So this is a summary from the literature for 93 cases of PLS in liver transplantation that has been reported in the literature. Since we don't have a large, well-controlled studies, we cannot predict the true incidence of alloimmunization. The alloimmunization rate ranges anywhere from 20% to 60%, and around 70% of these cases with serological evidence of alloimmunization, with no clinical or laboratory evidence of hemolysis. Not surprisingly, that anti-A and anti-B also are the most common in PLS, following anti-D. And there was also a 99 case study, or 99 case from the literature, that occurred after renal transplant, had a median time of onset hemolysis within 17 days post-transplant, ranging from 5 to 3 months. The highest number of cases occurred with O donor and A recipient, which was 44 cases, followed by O donor to B recipient. The risk is believed to be higher in O to A is due to the red blood cell expressing more antigen sites. So it's around thought to be around 800,000 to 1.7 million sites compared to non-A blood groups. So also in lung transplant literature review from 2009 to 2019, including 4 studies with a total of 11 patients in one study, showed that the ABO antibody was or were the most common with 67%, followed by D. One study looked back at 92 lung transplant performed at a single institution over 30 months. The report was just for the RHD related PLS and was approximately 1 in every 31 lung transplants, so around 3%. And it shows 75% demonstrated some degree of hemolysis. It also reported that the severity of PLS cannot be predicted based on the volume of lymphoid tissue present. While in other organ transplant, a literature review including 3 cases reported GI tract transplantation and 1 case of series of heart transplantation. 2 cases involved ABO antibody with clinically significant hemolysis from anti-A, while 1 case involved anti-M antibody without any evidence of hemolysis. So the detection. So diagnosis requires awareness in clinician. This is the first step. As often mild hemolysis will escape investigation, the recommendation is to just closely follow up with the patient during the next 4 weeks for any fall in patient hemoglobin level. They also recommend to use imaging, for example, ultrasound, to rule out any sort of bleeding. Also, we should do hemolytic workup, including hemoglobin level, LDH, reticulocyte, bilirubin, haptoglobin, and that. And also the peripheral blood film if there is a hematopathologist in the hospital. If the data was positive, it's highly recommended to do elution. And after confirming the diagnosis, we can think of the available treatment option. So the majority of cases will present with mild hemolysis, as we said, and will not require any intervention except for the close monitoring of the patient. If the hemoglobin level is within acceptable levels and the hemolytic parameters are within also acceptable ranges, conservative management of the patient is recommended. If the patient requires intervention, supportive treatment, including red blood cell transfusion, you should match it for donor-compatible units. And we can use steroids. If the patient is already on steroids, we can increase the dose to up to 1 milligram per kg if required. So if the hemolysis is not resolved or there was a massive hemolysis, which can be seen in rare cases, as we said before, a few treatment options, including red blood cell exchange, plasma exchange, the add of rituximab, IVIG, and as a final resort, we have splenectomy as a last treatment option. In one study, 6 patients who developed PLS after transplantation were described. They developed severe to moderate hemolysis. 2 out of these 6 cases had severe hemolysis. One of the patients required plasma exchange, while the other patient required up to 14 units of red blood cell transfusion. So I know it is a short topic, but PLS is not something common to usually see every day. So in summary, I've hopefully shown you today that PLS is an under-recognized cause of delayed hemolysis in solid organ transplant recipient and also the stem cell, especially if there is a brisk hemolysis that happens 1 to 2 weeks after the transplant. The rate of the PLS depends on the type of organ, or to be more precise, the dosage of donor lymphocyte that are transplanted in the patient. A minor ABO mismatch with O donor is the most common scenario leading to PLS, which means that routine ABO antibody screening, routine AB antibody screening will not pick up anything. Therefore, some studies suggest that routine monitoring of patients with that. But since we know that around 30% of all alloimmunized cases does not show evidence of hemolysis, and we know that that could remain positive for weeks after or even a month after a hemolytic episode, this raises the question of how can we best utilize the DAT and whether there is a better method that we could just use instead. And with that, I just want to thank you for your attention and would be happy to discuss anything. Thank you very much.
Thank you, Thamer. I have a practical question for you and the crowd, if depending on what you think and what other people are thinking. So, with these patients for non-ABO antibodies from passenger lymphocyte syndrome, I'm just wondering how you would treat these patients for the future for transfusion medicine purposes and cross-matching, because they will have had a history of an antibody picked up on a previous investigation, but it's a temporary antibody. So I'm just wondering, for the purposes of cross-match, how you'd proceed in the future.
So I believe that I've read few of the articles that said usually after the disappear of the antibody, and this usually happens after 3 months. So after 3 months, if the patient didn't have any symptom or didn't have, and the antibody itself has resolved, you can just give you just match the patient's phenotype. And however, if still the patient is having the antibody, no, we should match for the donor phenotype. This is what I understood.
And if the antibody has gone away, do you think that these patients would be eligible for electronic cross-match?
Oh, this is a good question. I'm not really sure, but I believe so, yeah.
So they're so rare. I want to know if, that was my biggest question. If anybody has experience in the crowd of whether you would consider these patients in the future with a confirmed passenger lymphocyte syndrome eligible for electronic cross-match if the antibody's gone away.
I mean, I think I would. It's almost analogous to sort of a passive antibody that has gone away. I think if we assume that the lymphocytes, for whatever reason, have disappeared after a couple of weeks or a month or a few months, then I think it's probably okay. That would be my.
Yeah, I mean, I think it makes sense because the antibodies are just from the donated product. So there's really no, like, it's kind of a one-off thing.
Go ahead, Oksana.
Oh, hi. Thanks. Yeah, I agree. I think I would probably just double check what our, let's say, bone marrow transplantation rules are, because there are certain rules in terms of when you can return to electronic cross-match after engraftment. So for example, if after 6 months would even be generous, but you could even say a full year, if you've had negative antibody screens, you could probably write some rules or policies in your lab as to when you're willing to return to an electronic cross-match allowance for that patient. So I think I probably wouldn't do it right away, but I'd want to make sure the antibody is certainly gone and enough time has passed, but then eventually do so.
Thanks so much. Does anybody have any other questions?
I guess I have a question regarding the solid organ transplant minor mismatched. From the studies that you read, Thamer, how did they sort of assess hemolysis? And although that might seem like a simple question, if you can sort of imagine a post-heart transplant patient, their hemoglobin is going to drop for other reasons other than hemolysis. I would even argue that their hemolytic markers might be lit up for other reasons other than passenger lymphocytes. So do you know how they measured hemolysis in these studies?
Yes. So mainly what they did is they did the hemolytic parameters, but it was I think the timing of the hemolysis itself. This is one of the main things. So for him, usually after maybe a surgery, you could see a spike in the hemolytic parameters. However, if they see the spike after 1 to 2 weeks, it's not. It's not explainable. So this is one thing. Other thing is the DAT itself. Usually the DAT prior to or after prior and after the surgery usually are negative, but after 1 to 2 weeks it switches to be a positive DAT. This is, I think, they can maybe correlate with both of these points. I hope this answers your question.
Yes, thanks, Thamer.
Any other questions? I had one that was maybe, again, more theoretical, mostly because we had a patient here who was post-liver transplant within a few weeks and then had a new anti-little c on a pre-transfusion testing. They obviously were multiply transfused. So I wonder what your thoughts are of how far you would work that up to determine whether it was like, would you do a patient phenotype to see if it was maybe a passenger lymphocyte syndrome, if they weren't hemolyzing, or if they were hemolyzing, or like it could be passenger lymphocyte syndrome that's not reacting to the patient's own cells, but to any transfused cells that had anti-little c. So I just didn't know how much other people are working these up, obviously looking for signs of hemolysis on the blood work and chatting with the clinician. But when there is a new antibody that is identified mostly in the lab rather than on the clinical side for having hemolysis, I just wanted your thoughts, Thamer, on approach to how you would deal with that.
So yes, probably I will not only see the phenotype for the patient, I will also phenotype, if it's possible, I will phenotype the donor just to make sure that this could be the donor side. Also, we will do elution just to double check that. I will do my work up in the laboratory just to ensure that we are covering everything there, and that the patient, if he requires a future transfusion, I can just follow up with the antibody, and maybe if the antibody disappeared, if it's a kid or something that could disappear after a few months, I'll just make sure that I follow up with the patient to ensure that if he requires any transfusion in the future, I will just give him either a match for his current or recent phenotype, or if this patient actually had a unrelated antibody to this transplant. I'm not sure if this explained it very well, but this is what I think.
Yeah, no, and I guess this was the scenario is just a new antibody, and because they're multiply transfused, then unless we had a pre-transfusion sample without having transfusion in the last 3 months, we couldn't really do a phenotype. So yeah, I just wondered how far it would be chased. I raised the possibility of a new alloantibody versus possibly passenger lymphocyte, but I didn't chase it beyond telling them to look for hemolysis.
That makes sense, yeah.
Yeah, I agree, Dr. Clark, that with your comment there, it could be a new alloantibody that could disappear. We've started to see a lot more of the DSTRs being reported, at least for us, that we find a new antibody. So, Rodrigo, did you have your hand up?
It was more of a comment, and it was kind of related to the question that I had asked Thamer. So I think, I'm not sure how many of you guys are aware, but we started as of 2022 for minor mismatch heart transplants that we do here at St. Paul's, essentially giving patients their own blood groups when the setting of an O heart going to an A recipient, historically we were giving Group O blood, but we started giving them their own blood group and just sort of passively monitoring for PLS through essentially whenever they had subsequent cross matches, if they were hospitalized, we would make sure that there wasn't funny things going on in the blood group. We also do a DAT, and we also look at the hemoglobin. And anecdotally, I mean, we've done 11 of these over the last, I mean, I haven't pulled the data recently, but I'm just looking at an email that I had with Tina and the gang here. So in about a year's time, we did about 11 where we transfused Group A instead of Group O. And anecdotally, we didn't really see any evidence of passenger lymphocyte syndrome, but we did save a lot of Group O blood, which is another thing to sort of consider in these times. But anyways, we haven't pulled the data beyond, but just a little bit of anecdotal experience here where we've actually gone away from giving Group O for these patients.
That's interesting. Thanks, Rodrigo. And do you guys just have the heart transplants at your site? So it would be our site that has the other transplants? Yeah, okay. I actually don't know what our policy is. It might be interesting to look. Any more questions or comments?
Just a quick question. Is there any sense of in the leukoreduction area if that's affected the incidence of this, or maybe you covered this and I just missed it?
See, this is a great question. So usually these are solid organs. So I think the lymphocyte sits within the organ itself. So the leukoreduction usually happens with the red blood cells or the blood unit itself. But however, for solid organ, it's a little bit different.
Yeah, I guess so. Because really, I wasn't even thinking it through because you're talking about lymphocytes in the transplanted organ, not anything to do with blood products, basically, right?
Yes.
Sorry about that. That makes total sense.
It's okay.
The other comment, sorry, the other comment that I had was to do with the incidence data. Like, I wonder how much of it was, and again, I have no idea about how these organs are procured and what happens, the processing, but I wonder if the incidence is different now than when we looked at it maybe in the 70s when the procurement of these organs and the treatment post-procurement was different. So I wonder if that also has anything to do with the incidence, where maybe the incidence is actually less now than it was before because of how we get these organs and how we manipulate them pre-implanting them, transplanting them.
Yeah, actually, yeah. So this is actually a great question. So the thing is, if you search the literature, there is actually the majority of the cases are retrospective studies, or there's no prospective study that could maybe look for what you're asking from the doctor. But I believe the incident itself, it will still remain similar. And this is just my guess. It will be similar. However, maybe with new techniques and new strategies that are followed, maybe if there is a prospective study that could actually help us with understanding more of this disease.
Yeah. Thank you so much. If there are no other questions, I will let you all go early. The next transfusion rounds are already scheduled, so they're on March 14th, and it's with the topic is the new radiation guidelines. And so we have two experts who helped draft these NAC guidelines, and they're going to come and chat with us. So yeah, please remember to do that evaluation for your attendance tracking at least, and we'll see you next month.
Thank you. Bye.
Thanks, everybody.